Great, thank you. Thanks for the moderators. Pleasure and honor for me to be here today. Good morning, and thanks to Venki for inviting me to this meeting. So, of course, it's going to give me a provocative name, challenge to TCAR. This is not a challenge to TCAR. This is, could there be an evolution to TCAR here? So, this is not moving forward. There we go. Okay. So I do have a significant disclosure. I'm the inventor of the device that's going to be discussed over here that's under trial, and also the founder and CEO of the company that's commercializing it. So please keep that in mind as I go through these comments and my subsequent talk as well. So this is a Neuroguard 3-in-1 carotid artery stent system. This was recently approved by the FDA. This includes a stent, a balloon, and a filter all in one. And the stent is a novel stent. It's a closed-cell nitinol stent, but very flexible with good radial strength. It has a balloon that's mounted underneath it already so that there's one less catheter exchange. You don't have to go in with a separate balloon. But most importantly, there's a filter distal to the stent and the balloon. It's integrated on the same catheter but activated independently. The physician turns a knob and opens up the filter. The filter then creates a full seal around the vessel and custom fits to a unique anatomy. And that filter has 40-micron pores in it to optimize embolic protection. Why 40-micron pores? Well, all existing embolic protection devices that exist in the U.S. right now, distal EPDs, all have pore sizes between 100 microns and 280 microns. And it turns out several studies have shown that 90% of particles that are released during carotid artery stenting, especially during the post-dilation phase, are less than 100 microns. So if 90% of the particles that are released are less than 100, and all distal filters have pore sizes more than that, well, some are going to get through, and you're going to have a higher risk of stroke. We'll talk about that more in the next talk I'm going to give. So this device was studied initially in Europe, and then a pivotal study was done in the U.S. with 305 patients. And here are the results from that on the right side. This has been published. 30-day all-stroke plus ipsilateral stroke to 1 year, 1.8%. There were 5 minor strokes. All patients fully recovered. There were no major strokes, no stent thromboses, no neurological deaths in the study. And when you look at this compared to previous results, either from carotid artery stenting with the transfemoral approach or endarterectomy in large randomized trials, these data compare favorably in this study. Of course, this is out of a pivotal study. Long-term data and post-approval studies are remaining. So with this device and the distal portion, which includes the stent, filter, and the balloon, this was available in Europe earlier than in the US with CE mark, and there's a physician by the name of Alex Malios who wanted to explore using this device, the transfemoral version, which was available in Europe, with a transcarotid approach. So he did 64 patients, treated 64 patients in 2 centers in and around Paris, using a commercially available transfemoral Neuroguard, which is a 140-centimeter device, using off-the-shelf Terumo sheets, and attached the Terumo sheath with a blood bag, and the blood bag was attached to the side port and positioned 20 centimeters below the carotid. No femoral vein access. All patients were done awake with local anesthesia. And in 22 out of the 64 patients, he performed transcranial Doppler in the petrous, ipsilateral petrous internal carotid artery. And of those 22 patients, 16 had usable images that could get good imaging through the entire imaging, including at access, at clamping of the common carotid artery, at initiation of flow reversal into the blood bag, and then during the various phases of the stenting procedure. And what was the reasoning behind this hypothesis? Hypothesis, we know endarterectomy has stood the test of time, but it involves closing off both the internal, the external, and the common. That's when you treat the lesion. TCAR involves getting access to the common carotid artery, clamping the common carotid artery proximally, attaching that, the way it's currently being done, to the femoral vein, creating a gradient, and then the thought being that that gradient will be enough such that all flow, reversing flow through the external or the internal, will result in all flow coming backwards and no flow going forward. Of course, the original way this was described was to exclude or occlude in some way or the other the external as well, and that's the only way you can truly isolate the internal carotid artery. The thought being for TCAR right now, the way it's being done, that if you attach the common carotid artery to a low pressure system, such as a femoral vein, you're going to have all flow going reverse, and no flow will go into the internal carotid artery. But the hypothesis here, or the question was, well, what if the ECA is patent and large, and the circle of Willis has low pressure? Could it be that you have some flow coming back, but you also have some flow going forward? And therefore, is there a benefit of having, in addition to flow reversal, a filter on the system as well to add additional safety to the procedure? So the way this was done with a transcranial Doppler positioned in the petrous segment and not in the circle of Willis, because that can have aberrant flow coming from the ACOM or the PCOM. So this is only flow in the ipsilateral internal carotid artery. And measurements were done at initial access, and then when the CCA was clamped, when the side portal was opened up, and through the various portions of the procedure with wiring, pre-dilation, stenting, post-dilation. And interestingly, what he found, and this has been published, was that in 8 out of 16 patients, and 50%, there was still antegrade or biphasic flow in the ipsilateral internal carotid artery, even though there was visual flow back into the blood bag, into the low flow, low pressure system, into the blood bag. So there was flow on both sides. Here's a representative example where you've got flow with the 8 French sheath in the common carotid artery, Terumo sheath, hooked up to a blood bag open, and you've got flow, biphasic flow noted in the internal carotid artery. In other cases, there was not biphasic, there was antegrade flow. So in total, 50% of patients. An interpretation of this group was that depending on the pressure differential between the internal carotid artery and the external carotid artery, there may be cases where you have visual flow reversal, but also antegrade flow at the same time. And this was a conclusion that common carotid artery clamping alone can sometimes result in reversal flow in the ICA, but not always. When he then opened the side port, either to a blood bag or a low flow system, such as the femoral vein, this does not always result in flow reversal in the ICA. And that flow reversal in the common carotid artery that you visualize can be provided by the ECA, with some still going to the ICA. And therefore, since this is not predictable, maybe having a filter during TCAR could add additional safety. And so that's where, as a result of the feasibility study done in Paris with the 64 patients and with these TCD data, a shorter version of the device was then developed, 70 centimeters instead of 140. And along with an access kit, this access kit has the traditional the needles and the sheaths and the wires that come along with it, but the sheath has a particular shape in it, which is that there is a upward bend to it such that it avoids the posterior wall of the carotid artery, hopefully reducing the risk of common carotid artery dissections, and also comes with a flow reversal system. But this is not attached to the femoral vein, it's just attached to a blood bag and has a low flow and a high flow system. The potential advantages over here are that you have the integrated filter, and there's the key potential advantage because of additional safety without any extra time or effort associated with the procedure. You have an integrated angioplasty balloon, therefore one less step, reducing procedural time. You have a new stent that is closed cell design with optimized flexibility and radial strength, no venous access, and a sheath with a preformed curve. And so this is being studied in the Performance 3 IDE study. This is being led by Sean Leiden and Chris Metzger, 149 pivotal patients, about 80 lead-in patients. About more than 60% of the study has been enrolled. We expect to have this enrolled in the next few months. A 30-day endpoint of composite of major adverse events, including death, stroke, and myocardial infarction. And for those patients who have a stroke or cranial nerve palsy, they would be followed for a longer period of time. Represent an example over here of a patient with a symptomatic stenosis in the left internal carotid artery. And you can see in this particular case, the integrated filter with debris in it, despite having flow reversal. And here's another patient that was just done about 2 weeks ago in the right internal carotid artery, just a representative example again. A symptomatic patient, ulcerated stenosis, no predilation, 4-minute clamp time, 124 centimeters blood loss, or cc blood loss in the blood bag. And that's approximately what we're seeing, somewhere in the 100 to 160 cc's of blood in the blood bag. And these patients tolerating this very well, all have gone home the next day. So in conclusion, the Neuroguard carotid stent system has an integrated 40-micron pore filter. The one-year outcomes of this via the transfemoral approach are very encouraging, with remarkably low stroke rates. Flow reversal during TCAR may not be consistent or predictable, and therefore there may be a role for additional embolic protection during TCAR, and this hypothesis is being tested in the Performance 3 study. Thank you.